Okay, thank you very much. Good evening. Welcome, everybody. So my name is Fraser Brims. I'm a consultant respiratory physician and head of department at Charles Gardner Hospital. I'm also at the new Curtin Medical School. And in my spare time, of which I have very little, I'm also Deputy Director for the Institute for Respiratory Health. So as you know, I've been asked to speak about early detection and lung cancer screening, which, as we will see, has become very topical in the last 4 weeks or so. So the learning objectives are there, and we'll wander through these. So why are we talking about lung cancer? Well, it's the commonest cause of cancer-related mortality and indeed morbidity in Australia. So there's more than 12,000 new cancers diagnosed, and the numbers are estimated to go up for at least another decade or so. So it's approximately 10% of all cancers in Australia, but 20% of cancer deaths. And we can see that there's a clear differential in outcomes in terms of 5-year survival from the other solid cancers that have enjoyed great improvements in 5-year survival, but lung cancers remain stubbornly poor. We'll look at some of the reasons why. One of them chiefly is that many lung cancers present at a late stage where attempts at curative therapy are simply not possible. And some of that is because they're advanced stage, but also the comorbidities, most commonly cardiovascular and COPD, restrict treatment options as well. And as we'll see, there are very few symptoms potentially of an early lung cancer as well. So with regard to sort of regional and remote figures, we can see this is our AIHW data from this year, and we can see again there's a consistent disparity in outcomes with 5-year survival for lung cancer, and that again is a multitude of reasons that many of you will be very cognizant of. But again, overall, it's very, very poor compared to other solid organs. So the two key risk factors are age and tobacco exposure. We can see that on the first graph here that lung cancer below the age of 55 is in fact very rare. It's not to say it doesn't happen, but it's but the vast majority of lung cancer cases are beyond age 55. And we can see that we know that when people quit smoking, their relative risk over about 10 to 15 years becomes nearly that of a never smoker. But the cumulative risk, because it includes age, in fact continues to be a problem. And you can see from this, at least in respiratory circles, rather famous graph, that your risk does increase even though you can give up, say, for instance, in your 40s. The orange line here will demonstrate that there's still a cumulative risk along with age. So, lung cancer symptoms, a key figure which has been consistently demonstrated across many studies in the last probably couple of decades is that patients often have a number of visits to primary care providers before their diagnosis. And again, rounded figures would be about a third of them have more than 3 visits prior. So the most common symptoms would be that of cough, dyspnea, chest pain, and of course hemoptysis. And I guess the real catch for us and the challenge is that cough, dyspnea are commonplace in people with COPD, and so will often be not so much ignored, but normalized or blamed on something else. Importantly, hemoptysis is not specific for lung cancer, but it is a very important red flag. So if someone's at risk in terms of tobacco exposure, in particular in age, then hemoptysis should be taken very seriously, as I'm sure you are all well aware. There are some more systemic, kind of more generalized symptoms as well, I guess, that would be consistent with many advanced cancers as well. So I guess the challenge for us is that these symptoms are, with the exception of hemoptysis, can be rather non-specific, and it's a case of noticing them and recognizing when these are worsening and in people that are of high risk. So one of the real challenges, again, is getting a consistent message or a message to at-risk individuals because there's, again, good data that people blame their symptoms on old age or their COPD, or they simply don't recognize that it's a more serious symptom. So I want to talk about this study called the CHEST Australia study, which actually was based at UWA here, and a lot of work around Perth and surrounds. So this is looking at trying to increase awareness of symptoms and increase potentially the patients making appointments with primary care because of their symptoms. So there was a fairly simple behavioural intervention. There's a large number of patients randomised, and the very simple criteria for high-risk people was more than 20 pack years of smoking and above 55. And the intervention was just to increase the salience and personal relevance, I guess the importance of symptoms, and to reinforce the benefits of early consultation. And there were some very simple action plans, such as if you cough up blood, you need to see your doctor within a couple of days, for instance. And what this demonstrated is that with this very simple intervention, there was a 40% increase in respiratory consults in that group. But interestingly enough, there was no the difference between the first consult or the time to first consult. So patients, even in the standard care arm, still were able to potentially recognise more serious symptoms. The paper itself wasn't looking at picking up lung cancer early, but the inference is that by a very simple intervention, we can improve patients' awareness of potentially important symptoms. And importantly as well, John Emery, who ran this study, used a data extraction tool, which essentially is a fairly simple program, which can be used on, I'm told, 3 out of 5 of the most commonly used GP databases. And it was able to pick out a population very simply of running, in particularly through age and using the smoking history as well. And we've been using this program actually in some of the research work we've been doing, which I'll talk about shortly. As a sub-study from this, we looked at, or not we, John in particular looked at the barriers to consultation. So what was stopping individuals on seeing their doctor? There's a great deal of guilt. There's smoker stigmatization. People think they're just going to die anyway, so what does it matter? And again, that key thing of normalizing symptoms, putting it down to age, putting it down to something else. So some really, really important messages from this study. So early detection, I guess the real problem is that small lesions, so anything sort of less than a couple of centimetres, depending on where they are, do not necessarily cause any symptoms at all. Now, I picked out this little infographic, which is actually from a sponsoring company, which just emphasises that screening and fact should be those that have no symptoms. And this little infographic lists off a whole bunch of symptoms, which are the right ones to list off. But then they say you should get screened. But of course, if you have those symptoms, then you're not truly screening. You're actually trying to case find in people that have symptoms. How best can we screen for lung cancer? Well, all of these methods lifted off here are being looked at or have been looked at in time. Just to make life easy for us, we can say sputum cytology doesn't work consistently, can pick up a few squamous cells, but it's no good for adenocarcinoma. Chest X-ray has been shown unequivocally to be of no benefit. It does pick up lung cancer, but not at an early enough stage to have a mortality impact. Circulating tumor DNA and other fancy biomarkers have potential. Probably the biomarkers might get in first in terms of helping us recognize at-risk people, or at least if we found a nodule, something we don't know what it is on a CT, it might help us. But I think we're still probably a decade away from any of those being useful. So we're going to concentrate more now on low radiation dose CT. And what we're trying to do is pick up what's circled in red here, which is just over 1 centimetre adenocarcinoma in someone that's high risk, and clearly something like that has no symptoms at all for the individual. Oh, it's not going to work. See if we can try and use that. Okay. So where Australia stands at the moment is very unequivocally that screening is not supported in Australia. And this is a statement which is nearly 4 years old and has not changed. I understand the Standing Committee to be reviewing this later this year when some other data gets published. But for now, this is not supported. So the unresolved issues from the committee are those of a high false positive rate. That is to say, we will often find indeterminate nodules, and those need to be followed up. And CT scans are not cheap. And that's one of the other big concerns. There's huge variability in all the studies around the world in how we should follow up these nodules. There's uncertainty in how we target a population that are suitably high risk. We can't just screen anybody who's ever smoked. It won't work, and it certainly won't be cost effective. And there's important data that we need to include smoking cessation, but how that can be included into the program is not entirely clear at this time. So what really put lung cancer screening using low-dose CT onto the map was a study called the National Lung Screen Trial, or NLST, from the USA. So 53,000 patients, landmark study, which showed that just after 3 annual screening rounds and 6 years of follow-up, there was at least a 20% lung cancer-specific mortality, and an all-cause mortality in addition. There's another study which is yet to come out, but I'm led to believe should be in the New England Journal in the coming months, which is the Nelson study, which is a very less large, but nonetheless extremely important European-based study, which has shown an even greater reduction of cancer deaths in men. And as other studies have sometimes suggested, and this is confirmed, a very significant increase in lung cancer mortality for women as well. So lung cancer screening, or screening for lung cancer, only works when you screen the highest risk individuals. So we need to have a targeted approach, and this is where lung cancer screening will be different, or is different, to just about any other screening program we have. The big American study used quite a simple paradigm, which is quite effective, which was to say that if people have got a 30-pack year history, less than 15 years since quitting, and are age 55 to 75, then that puts them in a high risk bracket. But the problem with that is it did work, but there is very heterogeneous risk for lung cancer. I've already mentioned that below 55 years old, very few people have lung cancer. But we can see from some analyses from the NLST study that there was, again, quite a variation in risk, and at the lowest quintile of risk, in fact, there was only 1 death prevented in 1/5 of the study participants. So this here, and potentially the next quintile, are very inefficient. And so potentially there needs to be an improvement in how we can target the high risk. These are the same data just presented, and over here on the right-hand side, it's just saying the numbers needed to screen in the lowest risk cohort are over 5,000, which makes it incredibly inefficient. However, in the highest risk cohort is 160, which is far better than breast and bowel screening programs. So the Americans used a bit of statistical further analysis, and they actually extended their recommendations out to age 80. And lung cancer screening has been happening in the US for about 4 or so years now, and it's supported by the US Preventative Services Task Force. But we've seen that it's not that good potentially, so there needs to be better ways of identifying those at high risk. And a way of achieving that is another New England study that came out some while ago, is actually using a sort of risk prediction model that is remarkably simple to use, very complicated stats, but what it boils down to is that over the phone or online, or even filling in the back of a postcard, patients can provide all these data, and that can be imputed into a model very simply, and it's an app on your phone if you wish, and that will spit out a risk of 6 years ahead of lung cancer, and above a certain level, and we think currently at the moment that's 1.5%, there we think is worth screening those individuals, and the statistical modelling suggests that we will be able to screen less people and pick up more lung cancer using this model, and I'll show you how we are testing that shortly. How many people in Australia might be eligible for screening? We did a little bit of work. One of my colleagues, Dave Manners, who works at St John of God in Midland, demonstrated that about 20%, so 1 in 5 of ever smokers, will be eligible. So if you consider about half the Australian population of smoke, so roughly speaking, that's only 10% of the population. So again, the challenge for screening for lung cancer, we can't just send a letter out from the Department of Human Services saying that you're aged between 50 and 74, therefore have a mammogram, because it doesn't work that way. We have to be able to target people far more specifically. So there's a very active group called the International Association for the Study of Lung Cancer, and they produced a position statement actually some while ago, but it still stands. It's saying that if you're having a screening program at a local or national level, you need a variety of, well, they recommend a variety of issues. So one is you must have very tight quality assurance and standards and governance within there. They, again, are strongly supporting a smoking cessation program. And of course, it's not just about lung cancer, but it's about COPD and, importantly, all the cardiovascular diseases and stroke as well. This is a very specialist area, and we need radiologists and surgeons and others who are prepared to make diagnostic calls on things that are hazy and maybe even just 8 millimeters big. So this is a new area for many of us working in here, and if you like, almost a little subspecialty area. Meanwhile, in WA, as many of you will have seen, we've had a number of radiology companies actively encouraging primary care and patients to get screened. And this is specifically against the Standing Committee on Screening's advice, and specifically against what Medicare are doing. And there's been a lot of confusion and conflict about this that I'm happy to talk about in questions if you like. The problem with ad hoc screening, as we know from many different types of screening programs, is generally the lowest risk people are the ones who put their hand up, and they are least likely to benefit. There's problems with radiation because people are not only getting the wrong type of scan to start off with, but potentially their follow-up of the pulmonary nodule, which we find in up to about 50% of cases. The follow-up can be too frequent. They don't need as many scans as they're getting. Clearly, there is a financial incentive to follow people up quite closely by private radiologists. We've seen, and I'll show you some data in a minute, that there is definite harm from unnecessary invasive procedures and surgery, as well as psychological harm and worry, because the follow-up times are 3 months, 6 months, or even 1 year, and there's a lot of time to worry about whether something is growing in your chest or not when you haven't been through a formal patient decision aid process and helping people understand a lot more about the process. And of course, there's direct financial costs for individuals, but also to our taxes as well. So what's been going on in Australia? So there's a demonstration study some while ago in Queensland, which proved that the NLST criteria that can identify high-risk individuals, and that worked well in the Queensland setting. I, along with Annette McWilliams in Fiona Stanley Hospital, we ran a small pilot study, and this really heavily lent on primary care support for recruitment. And it showed that primary care were very, very good at identifying high-risk people from purely and simply having a little checklist on their desk, just listing off some of the high-risk criteria. And we're working on publishing that shortly. And there's an ongoing program which is unique, in fact, to the world, that's run from Charles Gardner, looking at those who've been asbestos exposed, which also raises your risk for lung cancer. And we're finding lung cancer rates comparable to the large screening studies. And it's suggesting that occupational exposures, in particular asbestos, are probably very much more important than have previously been acknowledged. So the International Lung Screen Study, just very quickly, is across 4 sites in Australia, and in particular in Perth as well. And this is looking to answer the question about how do we identify the high-risk people? Do we use the American criteria, or can we use this PLCO risk model, which includes demography as well? And that's ongoing. We've nearly finished recruitment, so we're a few years off getting sort of final answers with that. So what happens when you screen people from the NLST? So this is tertiary specialist physicians taking part in landmark research. But we can find that a third of those screened had a nodule of some sort, and of those, 25 had an invasive procedure, that is to say a biopsy or a bronchoscopy, unnecessarily, and a third of them had a major life-threatening complication as well. A third of all surgery was on a benign lesion, and of those, about 1 in 6, again, had significant complications from that surgery. We can see there was vast overuse of another precious, very high radiation resource as well. A lot of inappropriate PET use in there as well. So here we have very experienced clinicians not doing it well. So it's a very specialized area. This is an infographic showing the same thing. So those are who benefit from lung cancer screening, which is only 3 in 1,000 from the American study. But in fact, we're harming 3 in 1,000 as well. So the balance of risk, in fact, is fairly fine, at least from the American data. The European study might hopefully be a little bit more reassuring. So these are false positives. These are pulmonary nodules. These are round lumps, and we don't know what they are. Which one of them is a cancer? Well, the answer is they all could be a cancer, and they could also all be benign or a little patch of infection. And that's the real challenge we have, because each and every scan needs to be carefully looked at, and then a decision made with each nodule as to when and how they are followed up. Don't try and read this, but this just lists off all the different definitions of a nodule. So across the world, we can't even decide what is significant. Again, so it's highlighting the fact that there's a lot of work to do in terms of even just deciding what is of significance on these scans. So bring it back to Australia, where are we up to? So just to be clear, at the moment, Medicare does not fund or support lung cancer screening. Ad hoc screening is often with those at low risk, and it's well outside current guidelines as well. And we've seen there are significant potential harms, and about 50% of those that are screened will have something that needs to be followed up. But who should be doing that? And are the patients being properly educated prior that this may well be the case? However, change is coming. It's not going to be quick, but it is coming. So even before well, actually, I was asked to do this talk, in fact, before this had happened. So on the 1st of August, Greg Hunt, Federal Minister for Health, has instructed Cancer Australia to look into a feasibility of a national lung cancer screening program, which is a massive, massive thing for us in this world, and years of work. However, it's not going to be quick. I think it'll be a good 5 years or more before we're seeing kind of fairly widespread process. What should it look like? I think a bit like breast screen, there'll be lung screen centres. There needs to be accredited radiologists that are reading perhaps 300 or 400 of these scans per year. There needs to be very specialised MDTs to interpret what to do with these very complex areas. And recruitment will be different to all other forms of screening in Australia. And I think primary care will play a very, very key role with this. Smoking cessation has to be a big part of this as well. My hunch is that there'll be demonstration centres, and one of those I'm sure will be in Perth, and then there'll be a wider rollout. So it's going to take time to get to there. This is an example of the kind of things we can see. So we've got a sort of what we call a part solid nodule, quite diffuse growing. So 3 months later, we can see that it's now larger and more solid, and that's a fairly rapidly growing adenocarcinoma. Other examples, this is an example of how things can get very complicated and take up a lot of time. So this was a screening scan through the international study here in Perth, and we can see a 5 millimetre solid nodule, and that just needs a 1 year follow-up. At 1 year, we can see it's grown and looking more spiculated and very definitely a very high risk looking cancer. So he gets a PET scan, which confirms that it's that is PET avid, and that will be appropriate in this case to go for a primary resection and a lobectomy. However, this has also demonstrated another area which has not been picked up prior. It seems very hot. A lot of debate about whether this is a patch of infection, but a bronchitis, or could it actually be another synchronous primary? He also had a hot node as well, but was that related to the recent infection or not? Or is it anthracosilicosis, which we see very commonly in people that have worked in dusty areas? He also had a thyroid nodule, which needs to be looked into as well. This one patient alone probably took up a day and a half of my time, and our nurse's time and otherwise. I'm pleased to say he's had a wedge resection of both those lesions, and it's 2 synchronous lung cancers. Picked up an early stage, and he doesn't require any further intervention. So it's a success, but it also highlights just how complex some of this can be. So we've seen that the burden of lung cancer in Australia is very high, both with mortality, but also morbidity as well. Take-home messages really would be tobacco smoke exposure and age are the most significant risk factors for lung cancer. Asbestos and other occupational exposures are very important. And lung cancer symptoms are non-specific, with the exception of hemoptysis, but it's not exclusive, of course. And often we've seen within patients that the symptoms are normalized and ignored and wrongly attributed by them to other other conditions. And just to be clear again, so Australia does not currently fund or support lung cancer screening. Change is coming. Ad hoc screening carries many risks and responsibility of those ordering the scans. And WA in particular, but across Australia, we're contributing some vital international research that is very definitely going to inform our practice as things change in the next 5 years or so. And my strong feeling is that primary care are going to play a really, really important role in any future program. So I thank you very much for your time, and I hope there's a few questions.
Thank you. So if anyone online has any questions for Professor Brims, just type it in now, and we can answer the questions, or he can answer your question.
Whilst things are coming in, some of you may be thinking about lung cancer in never smokers, which is an increasing recognition of, I guess, so it's happening. So up to about 20% of lung cancers now are in fact in never smokers, and that's far more common in women, and they're far more likely to be adenocarcinomas. The really frustrating thing is it's very, very hard at the moment to predict who it's going to happen in, or to even understand why it's happening. So they will not be part of any screening program because we simply can't identify who's at risk at this time.
It doesn't look as though any questions have come through. Just give another 30 seconds if anyone has any questions, just to type them in.
And if anything's coming, if anyone's going to think about vaping and e-cigarettes, there's no data on them causing cancer yet. I think in the fullness of time, it will be shown. It definitely causes airway damage. And there's been a rash of what's probably a hypersensitivity inhalational damage to patients in the US in the last week or so, and in fact to death as well. So there's huge concern with vaping and e-cigarettes, but we don't know about carcinogenicity at this time.
Okay, we have a few questions. Is strong family history of lung cancer is a cause for screening?
Not alone. So we know a family history of lung cancer bumps your relative risk by about twofold. But if that individual has not smoked, that being the most important risk factor of all, then certainly not. Tobacco smoke is the #1 risk. And then this PLCO model that I was mentioning includes small extra modifications to that risk. But in someone who's never smoked or a very distant history of smoking, then actually I would, under current guidelines, definitely not. And I would strongly imagine that wouldn't be under any Australian sort of lung screen type guidelines as well.
If suspicious based on symptoms of patient, first investigation will be, it says C X-ray or CT scan?
It's a great question. So many of the European and UK guidelines would say chest X-ray first, and pragmatically that's not a bad call, but on the other hand, you can't reliably say there's definitely not a cancer, even though chest X-ray is normal. So I think pragmatically, in Australia, where we're able to get hold of CTs in the community with relative ease, sometimes a little too easy, but actually if you're really worried with symptoms, particularly hemoptysis, then a CT would be entirely appropriate.
And maybe the last question, with these, I'll just read it as is. With these lung cancers in non-smokers, are the symptoms different?
Oh, that's a great question. No, is a simple answer. They histologically look the same. They're mostly adenocarcinomas, and symptoms are either none at all, as we've seen, which is one of the real frustrations, or no, it will be presenting in the same way of, cough, breathlessness, chest pain, hemoptysis, and then those systemic symptoms as well.
There is one final question, but I'm not sure if this has come through. I'll read it out and see if it makes sense to me. It says, i.e., should we be looking for more atypical presenting symptoms in these patients? Oh,
okay. This is sort of follow on to the last. So no, I don't think so. As to say, it's not histologically or clinically any different. It's just that it's it's hard to predict who these people are, I guess. But age would still be the number one thing for in terms of risk for any cancer, just about. So it's unlikely in people, and I think we are swayed by anecdote and things we see in the press and things intermittently about very young people with advanced lung cancer, which is very unfortunate, but also very, very rare as well. And we shouldn't allow it to mean that we start screening young people with, with radiation.
Okay, thank you. That looks like all of our questions, so thank you very much for joining us.
Okay, thank you very much.
Okay, good evening, everyone. Thanks for sticking around. I think it's getting quite late for some of you, but it's good that we still have your attention. So my name is Hooi. I'm a gastroenterologist at St Charles Garden Hospital, and tonight my component of the webinar will be to talk about screening and early detection in bowel cancer. Before I proceed, I'd like to also acknowledge our traditional owners, and in Perth, we are in Noongar country, and I'd like to say that it's a great privilege to be able to conduct our activities here. Okay, I'm trying to get the mouse activated. Let me see. Here we go. Okay, so today, my discussion will be about bowel cancer, which is also known as colorectal cancer. And Australia and New Zealand have the dubious championship trophy, if you like, of having the highest global incidence of bowel cancer. It is the commonest cancer affecting both Australian men and women. And I'll explain that in a bit more detail. It's a sort of statistical play of words a little bit, but it's a cancer that affects both men and women. And of those sorts of cancers, bowel is number one, with a lifetime risk of 1 in 10 for men and 1 in 15 for women. It's the second biggest cancer killer in Australia after lung, as you've just heard. And in 2019, it is estimated that about 16,500 people will be diagnosed with colon cancer or colorectal cancer, and about 5,500 people will die from it. So if we look at this table here, I'll explain the statistics a bit more clearly now. In men, the commonest cancer is prostate, whereas colorectal is second. Whereas in women, breast cancer is the commonest, colorectal second. And of course, most of you will know that breast cancer is not particularly common in men, and prostate cancer is even rarer in women. So that together, when you talk about a cancer that affects both men and women, colorectal cancer has this dubious accolade of being the commonest. So what are the risk factors for colorectal cancer? We like to think of it in terms of what can't be changed or non-modifiable at an individual level, and also what things can be modifiable. And this modifiable component is very important because historically the Cancer Council has had a lot of contributions in terms of public awareness and so on to improve this side of the equation. And this is probably the side that also is responsible for making countries like Australia so high in cancer incidence of bowel cancer. So if we first focus on the non-modifiable, age, of course, is something that is very important, like lung cancer. And of course, then there are also personal histories of bowel cancer and bowel disease, and family history of bowel cancer and bowel disease, which is sort of lumped in together with an underlying genetic susceptibility. So that we can't change. But more important, this right side of the table, the things that we can change, in fact, may be as important as contributing 50% to the burden of cancer. And the things we're talking about include inadequate dietary fiber, excessive red meat and or processed meat consumption, obesity and physical inactivity, high alcohol intake, and smoking. And a lot of these also overlap, which substantially adds to the risk in an individual. If we look at the incidence by age, interestingly, I didn't know that much about lung cancer, but you can see that the age effect is not dissimilar, with by and large little disease under 40 years of age, but from 40 onwards, you can see this progressive increase in bowel cancer incidence. The word exponential is often used. I don't know whether that's mathematically correct, but you can certainly see that from 40 onwards, and especially 50 up, it really starts to increase in incidence. And now if we look again at the modifiable risk factors in terms of a quantification of the effect, this is quite a well-quoted study from David Whiteman's group in Queensland. And if we think of the percent of bowel cancer cases attributable to the various risks, we can see that inadequate fiber consumption is important, with about an 18% risk. Red meat and processed meat is also very important. And so when we tell people to cut down on that, we would say something like a palm-sized serve of meat consumed 2 to 3 times per day would be about the maximum we would recommend for red meat. 2 to 3 times a week, I beg your pardon, not a day. Processed meat, probably the equivalent of even as little as a slice of ham, about 50 grams or so. Again, 2 to 3 times a week would be about the upper limit of what we would consider acceptable. And of course, you know, many of us have come from a culture where things were advertised, meat eating, feed the man meat, that was all part of the campaigns and so on. And that sort of advertising, those sorts of recommendations or promotions should be now really taken with great caution, because we don't feel that they are applicable from what we know today. Alcohol is often considered a cirrhosis problem or a brain function problem, but we know that alcohol is also a very important risk factor for many cancers, not just colon, but for many other cancers, breast, esophagus, and so on. And the contribution in colorectal is about 9%. Physical inactivity, about 5% here, with body fatness, about 9%, but cumulatively, these two often go hand in hand. In fact, all of these factors often go hand in hand in an individual. And so you can see before you know it, there are very substantial cumulative risks contributions. Smoking, about 6%. Again, people think of smoking as just lung, but smoking also produces a lot of toxins and mutagens which affect the bowel. It's very important for people to understand, though, that in the biology of bowel cancer, there is by and large a very slow process that begins from normal mucosa to a small lump, which progressively becomes a bigger and bigger lump. And these lumps, which are still benign, we can call them polyps or adenomas, as shown on the left here. This is about a 10 millimeter or so lesion, which takes many, many years to become something on the right here, which is a big colonic mass, which occupies, say, half the luminal space and is friable and has a tendency to bleed. So this whole timeline can take anywhere from as little as 5 years, but typically more like 10 to 15 years. We can see that when it's a lesion of that size, a small lesion, like 10 millimeters, we consider that these are essentially asymptomatic. Whereas when it becomes a much bigger lesion like this, there can be bleeding overtly, and there can be some changes in bowel habits, as well as some low-level obstructive symptoms. It's also important to understand or realize that only 5% of polyps will ever become cancer. But of course, it's hard to know at this stage which ones are in the 5% versus which ones are in the 95%. So by and large, at this stage, if they are found in colonoscopy, they are removed. But it is important to take home that it's a slow process. We have a fairly good understanding of the biological timeline, and we also have a fairly good understanding that if we remove it at this point, it will stop the cancer from forming. So as I said before, polyps are considered often, virtually always asymptomatic, and so too a small early bowel cancer is considered to usually be of no symptoms, so asymptomatic. So you can see that to have symptoms, the tumor needs to be of a significant size. And so what are the symptoms that then occur when a tumor reaches a significant size? Well, by and large, the most important is rectal bleeding, which is overt bleeding. But there can also be covert bleeding, which then leads to anemia. And the most important of the anemias are the iron deficiency form, because that often indicates that there has been covert bleeding. And you can see that even if a leak is 1 teaspoon a day, you can see before you know it, you've lost a glassful or a cupful. So anemia is important, especially iron deficiency. A change in bowel habit, which occurs more recently or more acutely, is important. And of those, instinctively, many people think constipation, but by and large, diarrhea is the more important of the symptoms. Abdominal pain can occur as a consequence of low-level obstruction, but when very advanced, tumor can also cause local neural infiltration, but usually that is very advanced and typically more in the pelvis, and that's serious. Weight loss can also be a presenter, but by and large, weight loss without colonic or bowel localizing symptoms is a very low yield for bowel cancer. However, weight loss with localizing symptoms is a completely different ballgame, and that is an important indicator of possible colon cancer. So this is a chart that has been put out in a program from the Cancer Council, an initiative which is part of the Find Cancer Early initiative, which includes also charts for lung cancer, breast cancer, and prostate cancer. And I think that in either an email or some handouts, electronic handouts that have been given to you, you might find links to find these other charts, not just for colorectal, but also for lung, breast, and prostate. But if I just focus on this tool in bowel cancer, it's basically a chart that shows you a cross-reference between symptoms or some sort of presenting problem, and the probabilities that these presenting problems are due to cancer. And there is a statistical terminology here introduced called the positive predictive value. And if you look at this chart, basically it says to you, if a person presents with constipation, what is the likelihood they will have cancer? And the answer is about 0.42%. Whereas if they have, let us say, rectal bleeding, the likelihood is 2.4% that there will be a colon cancer. And the chart is marked in a way that the white colors are low probabilities, like less than 1%. And then as the color grades up to yellow, the percentages increase, and orange higher, and then red is the 5% and over indication or presenting symptoms. And typically in the red zone occurs when there is a cross of two different symptoms. So for example, an abnormal rectal exam and diarrhea, suddenly the risk becomes 11%, or two presenting episodes of rectal bleeding raises the risk from 2.4 to 6.8%. So it's important to know the high risk ones, but also the low risk categories. So if I show you the mathematics of it again, positive predictive value of a symptom is the true positive divided by the symptoms, or the true positives and false positives, multiplied by 100. So pragmatically, you can think of it as being patients who have the disease divided by the patients who present with the symptom. In other words, the probability of cancer for a given symptom. So If you look at single symptoms, the PPVs are not that high, and interestingly, all of you will have come across all of these presenters, and this table is particularly useful. It's applicable to people over 40 years old in this case, and you can see that just constipation alone, not particularly high risk, diarrhea alone, not particularly high risk, abdominal pain alone, etc., by itself, not particularly high risk. But when we start crossing over, you can see that I've highlighted especially the red zone ones, that rectal examination, which is abnormal, together with bleeding, suddenly the risk goes up to 8.5%. Abnormal rectal examination with loss of weight, it's 7.5%. Anemia, a low hemoglobin, less than 10, together with abdominal pain, and the risk goes up to 7% roughly. And so this is how you can use this table, which is quite useful to try and stratify the people who will need to be taken more seriously or investigated more urgently. So besides using a table, there are also other sorts of indicators to suggest high-risk presenters, and a palpable abdominal mass is one. And of course, if there are already imaging abnormalities, for instance, a mass seen on CT or uptake on PET, and as PET is being used more and more for staging other cancers as well, we are finding a lot of cases of people who are inadvertently found to have colon cancer on account of PET scan uptake. So those are the other high PPV indications. And here, in a more narrative sort of style, you will see, various referral guidelines and so on, including the ones that are used by the Department of Health to tell you who category 1 patients are or high-risk patients. And they will be in a narrative style. They will say things like chronic rectal bleeding, especially if it is sustained. Iron deficiency, as I mentioned before, because it's a marker really of bleeding. And the iron deficiency becomes more urgent if it is associated with significant anemia. So, for example, in males, if the hemoglobin starts falling below 11, it becomes a higher risk category than if the hemoglobin was unchanged. In females, if postmenopausal, if it's less than 10, or premenopausal, less than 9, it again raises the alarm category, if you like. Change in bowel habits for over 4 weeks, plus an alarm symptom such as a palpable mass or anemia or weight loss, again becomes something which needs to be dealt with more urgently. And then the next thing I will talk about later, the National Bowel Cancer Screening Program. If anyone has a positive FOBT on that program, that would be deemed a category 1 sort of referral. And acute diverticulitis is also said to be a red flag symptom, because sometimes cancers can present like acute diverticulitis, and on scans they will see an area of thickening, and we don't know whether it's due to a mass or whether it's just purely due to the diverticulitis. So we say first episode because they need to be investigated, and then thereafter, once we have seen that it's not due to a cancer, then subsequent episodes we know can be most likely due to just diverticulitis alone. We don't have to be concerned that there is a cancer underlying. Okay, equally, in terms of resource utilization and so on, one of the big problems with colonoscopy, and everyone knows about colonoscopy waiting lists, it's a national problem, it's a global problem, and one of the problems is this: the colonoscopy waiting lists are often swamped by a lot of background noise for low-yield colonoscopy requests, and they include young patients who have bloating, people with chronic constipation, people who have surveillance intervals too early compared to the recommendations, those with a weak family history where it is not first degree, when they present at older age, when the family members present at older age, or when there are not many family members affected. So that would not be a particularly strong family history. And when we colonoscope these people, the chances of finding something substantial is pretty low. And of course, a prior colonoscopy means that someone has had an all clear. Colonoscopy is very, very accurate, over 99.9% accurate for cancer. And we know from the biology of colon cancer, it's a slow growing process. So we know that if they've had a prior colonoscopy in the last 5 years, the chances of them having a cancer within that 5-year time frame is closer to 1 in 1,000. So well below 1%. So all of these things are important for how we triage referrals. So I have given you an idea that symptomatic presentation requires a certain mass effect. And so we know also from mortality studies that 25% of bowel cancer presentations are at a point where it is incurable. So you can look at it and say, well, 75% present and they're still curable, but really there are ways to try and catch it earlier. So because we know that at presentation, 95% of cases will need an operation to get rid of the primary mass. And in less than 5% of cases is the cancer so small that we can just lop it off by an endoscopic procedure, for example, by snaring it off during colonoscopy. So the real question is this: can we find bowel cancer earlier? And we get the hint now that probably if we can, then we can improve the outcome of bowel cancer. And so we can. Bowel cancer is an ideal disease for screening, and if you use the various WHO, the World Health Organization guidelines, it fulfills virtually all of them. And in a condensed form, these are the major points of the guidelines. It is a common, serious disease. There are no symptoms during the early phases. So is there a way to find it during the early symptoms before symptoms occur? We know that early detection simplifies treatment. We know that early detection improves outcome and survival. And since 1993, there have been big population-based studies that show that screening has been proven to save lives. So we've known this for a long time. And so I can only say to Fraser Brims, who gave the previous talk, be patient, because when the evidence becomes strong enough, there will have to be a screening program for lung too, provided there is evidence to show that it is efficacious. And it takes a long time between the presence of evidence before the government starts to effect it as a true implementation program. So with that strong evidence for a long time, the National Bowel Cancer Screening Program began. It began in Perth or WA in 2007. And it's a kit that's sent to people at home in which people have to take 2 samples of, I call it the dipstick test, 2 samples, small fecal samples to send back to the government. So I keep saying to people, please participate, because you only get this chance. It's your only chance where you can give the brown stuff back to the government. It's very rare we have this opportunity, so please do not squander it. So the test that they use is called the immunochemical fecal occult blood test, which in itself has a sensitivity of 83% for cancer. So it is not as accurate as colonoscopy, but we're talking about a test that we spray out to the population. So the sensitivity is 83%, but we know that when the test is repeated, we get a second chance to try and catch this cancer. So in regular testing in time increases the sensitivity. It has a positive predictive value of about 5% for cancer. So when the test is positive, it means that 5% of positives will be harboring a cancer. But it can also pick up some of these advanced polyps, the bigger polyps, which haven't quite become cancer yet, and it can also pick up some of the smaller polyps. Okay. Importantly, we know that when someone has a positive FOBT test, they are 60 times more likely to be harboring a bowel cancer than if they were negative. So again, this focuses the resourcing, and it is a much more efficient use of colonoscopy to say, well, go for the people who are positive, much more likely to be harboring trouble than if they're negative. So at last, you know, it's now 2019, 1993 it all began. 26 years later, at the end of this year, the program will be what we call fully implemented, because it started off in dribs and drabs, and many of you know that. It started off where only certain age groups were given the kits, but now between 50 to 74, at a 2-yearly basis, everyone will be getting the kits. In Australia at the moment, there's a 40% participation rate, and 8% of participants turn out to be positive. And of those participants who are positive, in the current screening program, 4% of them will be found to have cancer. Because of the audience tonight, I just wanted to highlight a few other statistics with this program currently. If we look at participation rate, the inner regional areas have a 45% participation rate on average nationally, whereas the very remote areas only 28%. So this is an area that needs to be further addressed. And then when we look at very remote versus major cities, here are some statistical differences. I apologize, this came from the program monitoring report, but about the size of the script, I apologize for that. But you can see very remote, the participation is 27-ish%, major cities 40%. Screening positivity, about 9.6% in the very remote, whereas it's a bit lower, 7.7% in the major cities. The diagnostic assessment rate is the rate of people who are positive who end up having a colonoscopy, only 50%, whereas it's 70% in the cities. And they wait longer in remote areas, very remote areas. 65 days they wait for their colonoscopy versus 51 days in the city. The bowel cancer incidence, fortunately, is slightly lower in remote areas, being 113 to 100,000 versus 127, whereas the mortality rate is the same. Again, for some of you in the more regional and remote areas who deal with Indigenous patients, you can see this is a big problem. Only 21% participation. They have a higher positivity. They have poorer access to colonoscopy, 51 versus nearly 70%. They wait a lot longer for various social and access problems. They have a higher incidence of bowel cancer, and they also have a higher mortality of bowel cancer. So these sorts of things are being addressed with various initiatives and assessments to try and see how to improve Indigenous participation and access to services. Okay, we know this program works because we have found that cancers are detected at earlier stages. Participants, 40% of them with cancer are found at stage 1, 3% only at stage 4, i.e. metastatic. So stage 1 is an almost curable stage, over 90% cure rate. So participants, a lot of stage 1, whereas non-participant cancers, in other words, those who present by other means, the stage 1 findings only 20%. So a significant reduction in people who are presenting early when they do not participate in the program, and a higher frequency of people who have already got metastatic cancer by the time they present. So we know that the program therefore finds cancers earlier at a much more curable form. And already we have found that there is a 15% reduction in cancer mortality as a consequence of the program, even when you correct for, after correcting for lead time bias. So currently we know one of the biggest initiatives will be to increase participation as a high priority. If participation could go up from 40% to 60%, there will be billions of dollars saved, let alone quality of life improvements. So in summary then, bowel cancer is a very common cancer. It is mainly a disease that affects middle and older age people. We know that early diagnosis improves outcome. I should have also said that there are many things that we can do and intervene in terms of these modifiable risk factors at a public health level, which can prevent or reduce the incidence of cancer. We know that specific symptoms have higher rates of positive predictive values for diagnosis, but equally we know we should try and avoid over-investigating low PPV symptoms, because that will be a waste of resource. And we know that therefore participation in the program, the National Bowel Cancer Screening Program, should be encouraged. So that's all I want to say for now. Thank you for your attention, and I think I'll wait for any questions. We're a bit over time, but that's fine.
Thank you. So if anyone has any questions, just type them in now, please. Okay, we have a question.
Okay.
If someone throws out the screening kit when you recommend it, but they would like to participate. How do they get another kit?
Okay.
Also, there's two questions in one.
Okay.
Also, can people choose to continue to participate beyond 74 years of age?
Right. Okay. So the first thing, the kit, there is a hotline. If I don't have the information here, but there is a hotline which you can phone call, or you can go online to request another kit if you have displaced or misplaced or for some reason were unable to do the first kit that came through. So they'll replace that. The second thing is over 75. The data do not, there is not good evidence that screening beyond 75 or 74 is of benefit. There is a suspicion that as people have been living longer, and a lot of these trials were conducted a while back, perhaps up to 80 would still be beneficial, but because of the cost effectiveness and so on, it is not funded within the National Bowel Cancer Screening Program. So there are ways to get a kit from a pharmacy and so on. You can buy the same kind of kit, immunochemical fecal occult blood test, but that will have to be separately funded by the individual. It's largely to do with a government-based cost effectiveness and data sort of issue. But beyond about 80, I don't think it should be encouraged.
Okay, a few more questions have come in. Is there a role for GP to order the FOBT in low PPV symptom patients?
So the answer is yes. There's a whole literature on that, and the answer is yes. There is value in it. Historically, we have not talked about that because there was a notion that people should be considering this test as purely a screening test, but in fact, it is an important stratification tool, and the current updated guidelines from the Cancer Councils, which have the badging of the National Health and Medical Research Council. So if you look up under NHMRC guidelines for colorectal cancer, there are recommendations of how you can use an immunochemical fecal occult blood test as an assisted component of risk stratification in terms of trying to change your PPV or to give you a better indication for someone with a low PPV presenting symptom. Yes.
If someone had a colonoscopy, when do you repeat the FOBT?
Okay, so if the colonoscopy, that's a very good question, and it is one that causes confusion. If they've had a colonoscopy, for example, if they were part of a first round of screening, they were found to have positive, you do a colonoscopy, not much is found. The recommended next time is to skip one round of screening, and so approximately 4 years later, you will get the participant will get another kit, and that is a time to re-participate in that. If a colonoscopy has been done, for example, polyps, and polyps were found, etc., or some other abnormality, they should follow the algorithm that then belongs to whatever was found. So typically polyps, then they exit the screening program pathway, they go down a polyp surveillance pathway, which will recommend different colonoscopy intervals depending on what is found.
Okay, and this is the last question.
Mm-hmm.
What is being done to increase the capacity for colonoscopies? If there's an increase in participation in screening, there'll be a commensurate increase in the number of people requiring colonoscopy.
That's a very good question, and the truth of the matter is this. The program itself, participants in the program who come back positive overall, even as the program expands, make up 10%, less than 10% of colonoscopy demand. So arguably some of the colonoscopy demand has been due to the program raising awareness and increasing anxiety in a lot of people, so that therefore awareness results in a drive to have more colonoscopy. But the reality is that the program itself only takes up less than 10% of colonoscopy demand. So the real answer is to try and better regulate requests for low yield or low PPV procedures. And that is a very important aspect where both the departments of health, individual health services, hospitals, and at the federal level, there are numerous sorts of initiatives to try and see how to discourage excessive use of low yield colonoscopy, so that better resourcing, better time intervals, and so on can be directed towards the truly needy cases, be it symptomatic or program participation. So to focus more on the high yield, high PPV cases.
We've had one more question come in, so we'll make this the last one.
Yeah.
If a patient had a colonoscopy done with a polyp removed and recommended to have a repeat colonoscopy in 5 years, should they do the bowel screening kit in between?
So the answer is probably they shouldn't. I say probably, but the guidelines say absolutely they shouldn't. They should just stick to the polyp surveillance pathway.
Okay, thank you. Okay, so that concludes our webinar for this evening. So just thanks again to our two presenters, Professor Fraser Brims and Dr. Hooi. So thank you for joining us this evening.